Good evening, everyone, and welcome to the Asia Pacific Glaucoma Society's webinar on glaucoma imaging. My name is Ki-ho Park from Korea, and I'm your moderator for today's webinar, together with Tony Tombokon from the Philippines. Tony, can you say hello to the attendees?
Hi, everyone. Welcome to our webinar for the month of February.
Okay, before we get started, we'd like to go over a couple of items. APGS is open to everyone who is interested to become a member of the society who are in this field, from ophthalmologists, researchers, trainees, specialists, associates, and corporations with the affiliation in glaucoma. There are many reasons to join APGS, and on the screen are just a few items which we can share with you. By joining APGS, one of your many benefits is that you can gain access to all recordings of the previous APGS joint symposiums, masterclasses, and webinars. You may scan the QR code on the screen on the slide to register as a member of the society. One final disclaimer: presentations are intended for educational purposes and do not replace independent professional judgment. After the conclusion of this event, you will receive a short feedback survey, and we'd really appreciate you taking a moment to complete it. I also like to take this opportunity to thank Carl Zeiss for their generosity in supporting today's educational activity. To introduce our first speaker, may I call on Professor Tombokon?
Thank you, Professor Park. Yes, thank you again. Good evening to everyone. Good evening to our virtual attendees. As we all know, imaging in glaucoma has developed at a very fast pace the past 20 years, and it has become an important tool in the diagnosis, monitoring, and management of glaucoma. We are quite fortunate that we have two well-renowned speakers who have done extensive research and are considered authorities in this field. They will share with us their thoughts and insights on the different types of glaucoma imaging modalities and how we could utilize them to diagnose and manage our patients appropriately. To those who may have questions during the speaker's presentation, please type your questions in the comment section. To introduce our first speaker, Professor Christopher Leung. He is the chairperson and clinical professor in the Department of Ophthalmology at the University of Hong Kong, where he also serves as the director of the Glaucoma and Optic Nerve Research Center. He obtained his master's in molecular medicine at the Imperial College London and completed a clinical and research fellowship at the Hamilton Glaucoma Center at University of California, San Diego. His research focuses on glaucoma diagnostics, OCT, and neuroprotection. He has obtained several awards from ARVO, WGA, APAO, and AAO, among others. Professor Leung has numerous publications on glaucoma imaging and is considered an authority in this field. Tonight, he will give a talk on if we need anterior segment OCT for the diagnostic evaluation of angle closure. Professor Leung?
Thank you. I hope you all can see my screen. Thank you very much, Tony and Kiho, for your kind invitation, introduction, and it's a pleasure speaking with you here this afternoon for this webinar. These are my disclosures. I am using the Anterior from Heidelberg Engineering and the Cassia 2 from Tommy for anterior segment imaging. The two questions that I would like to address this afternoon is, what is the current OCT technology for assessment of iris trabecular contact? And second, what is the role of anterior segmental OCT in the diagnostic evaluation of primary angle closure? Those of you who have a smartphone with you, please put it up, and I have some polling questions for you. The continuum of primary angle closure disease starts from primary angle closure suspect, primary angle closure, and then to primary angle closure glaucoma. We know it is the progressive development of iris trabecular contact that characterize the spectrum or the continuum of primary angle closure disease. From the elevation of ventricular pressure because of this progressive increases in the ITC to the development of peripheral anterior synechiae, and ultimately, if the pressure is high enough, long enough, then the optic nerve will get degeneration. This is the spectrum we're talking about. We have pretty good idea about how we define angle closure clinically. We rely very much on goniooscopy, and all these definitions, PACS, PAC, PACG, they are all predicated on goniooscopy assessment of the trabecular meshwork. We define angle closure typically when we couldn't see the trabecular meshwork or posterior trabecular meshwork, to be precise, for at least 180 degrees. This is how we define angle closure. And all these entities, PACS, PAC, PACG, are all rely on this fundamental definition. We have pretty good idea about how to manage patients with primary angle closure and primary angle closure glaucoma. We typically will administer laser peripheral iridotomy for these cases to prevent acute angle closure, and in some cases, we can also reduce intraocular pressure by performing LPI. The EAGLE trial also demonstrate the fact that we can also perform lens extraction for these individuals. But less is clear about how we should manage patients with primary angle closure suspect. From the SAP trial, this clinical study performed by Mingguang He provides some important insights into whether LPI is meaningful, is useful in patients with PACS. They conducted a pretty long-term clinical trials lasting for 72 months, involving nearly 900 individuals with PACS. And what they found is actually very interesting. They reported the incidence of PAC development or acute angle closure development are actually very low. The endpoint they are studying, they are looking at is the development of either PAC or acute angle closure. So the numbers we're looking at here, 19 in the LPI group, 36 in the control group, they are about the development of PAC or AAC. So overall, we're talking about 2% for those who receive LPI and 4% for those just keep observation. And you can see the incidence is actually quite low. And the conclusion of this paper is that widespread prophylactic laser peripheral iridotomy for PACS is not recommended. Now, this is what we learned from this paper. And here is a case I saw a few just some time ago. And this is a 58-year-old lady who came for routine examination. What we found here is by goniooscopy, dark room goniooscopy, we couldn't see the Sharpie's line, so we graded 1 for both eyes. The intraocular pressure was normal for both eyes. The visual acuity was excellent. And when we look at the optic disc, this is the retinal nerve fiber, GCIPR analysis, they are all normal. And I would like to ask your opinion at this point. You can pick up your smartphone if you have it with you, scan the QR code, and I would like to get your opinion about whether you would perform LPI in this case. So I hope you can pull out your phone and you can scan the QR code and you can start voting. All right, we are having more and more feedback, and we are looking at kind of quite an ambivalent opinion. And half of the audience here actually would do an LPI, and half of you would not. I mean, even given the background, we have the study showing that, you know, LPI is not recommended for all eyes with PACS, but still, we can see our practice actually vary. And we have about half of our group would perform LPI, another half would not. So now, why we need to perform LPI? The very reason here is the fundamental pathophysiology of angle closure. We know that the landmark or the anatomical key elements we're looking at here is relative pupil block. When we have an increase in resistance between the pupil margin and the lens, the aqueous get accumulated behind the iris, creating an upward force pushing the iris interior. And this creates the bouquet of the anterior chamber angle. The aqueous no longer can drain into the TM, and this is how the pressure goes up. And by performing LPI, we can actually equalize the pressure gradient. We have a higher pressure gradient behind the iris, and by performing an LPI, we can equalize this pressure gradient so that we can have equal pressure between the anterior chamber and the posterior chamber, pressure behind and in front of the iris now being equal. Then we can see the iris consumes now a more normal configuration. Whereas in eyes with angle closure, we see this typical anterior convex iris configuration, demonstrating that there is a pressure gradient. The term we coin here is iris trabecular contact. The peripheral iris is contacting the trabecular meshwork. So this is actually the key element we want to identify in patients with angle closure. But unfortunately, the concept of gonioscopic angle closure is actually quite different from anatomical angle closure. When we see this adhesion or contact between the iris and TM, this is iris trabecular contact, ITC. But having an angle being not visible, having the trabecular meshwork not visible for 180 degrees doesn't mean that there is iris trabecular contact for 180 degrees. This is two case example demonstrate the point I just mentioned. All this, we have two eyes here, the angles we graded, we're all one, but you can appreciate there are different degrees of angle narrowing. Here on the eye, on the right-hand side, you see ITC, you see the contact of the peripheral iris to the TM, but there are, for the other angles, there are different degrees of narrowing, which we can't really differentiate just based on gonioscopy. We have better tool now. We have the anterior seminal OCT. This first generation of swab source anterior seminal OCT was introduced more than 10 years ago. And now the second generation was introduced about 5 years ago. The second generation has a higher scan speed and a higher scan resolution. The important feature here is that we can actually scan the eye for 360 degrees. We don't typically rely on anterior seminal OCT for evaluation for angle closure because it takes a lot of time for us to go through all the meridians, and for the definition of angle closure, we just learned, we just heard that we need to actually see everything. We need to see 360 degrees, and when there is more than 180 degrees of angles being abnormal or being closed, then we will call this eye to be angle closure. So typically we can't rely on just one or two B scans to tell whether this eye has or has not angle closure. But in the clinic, we don't have time to go through every scan. So we develop a tool with Tommy to optimize this process. This is called STAR 360-degree. Is scale spread tracking for angle analysis and registration for long form. What this algorithm does is that we rely on manual detection of the scale spur. And then there is an algorithm to automate the process and identify the plane of the scale spur of an eye. Obviously, we can now use AI to identify the scale spur, but we often would require human assessment to check whether the scale spur is correct to identify or not. So either human assessment or AI assessment, you can rely on STAR to get you a bad picture of what's going on. And this is just a video capture to demonstrate how this is now available in the Cassia 2 device. We basically, after less than 1 second of scan, we perform 18 radial scans on the eye. And then by selecting 4 cardinal scans, we locate where the scale spur is. The software actually automatically identify the scale spur, but they may not be entirely accurate, so we can still adjust the position of the scale spur if they are not correct. And then the software will automatically identify the scale spur in the rest of the speed scans. So all the 18 speed scans contributes to 36 angle location measurements. The identification of the scale spur is important because a lot of measurements we perform using anterior segment OCT rely on the scale spur location. For example, AOD, angle open distance, TISH, trabecular iris space area, they are all relying on the scale spur to give you the quantification of the angle dimension. Here are the examples demonstrating the polar plots, 36 angle locations with AOD 500 and AOD 250 reported. Now, obviously, you can have different quantification measurements, TISA, TIA, but just give you an idea so you can have what this star can do for you. And we performed a study with a group including Makoto and Hara from Japan, Xiulan Zhang from China, Zhongsan, Shanlin from UCSF, and Tina An from Singapore. What we are looking at here is we are asking 4 questions. We are evaluating how much this technology, ASOCT, for evaluation of ITC is useful in detection of goniooscopic angle closure. The first question we ask is, where is ITC detected in eyes with goniooscopic angle closures? So we have about 170 patients from 5 different sites around the world, and they all have angle closure defined by gonioscopy. We have PACS, we have PAC, we have PACG in this group of patients. What you notice here is we are showing the frequency polar plot, and we are measuring AOD 500 0. Now, this is the definition we adopted in the study. That means the iris is closing at the TM for about 500 micrometer. So this is the definition we used in the study. And the polar plot demonstrates how often that this AOD 500 equal to 0 millimeter happens. And we found ITC is most often observed of the superior and inferior meridians. You can see many eyes over the top and the bottom superior and inferior meridians had ITC, and the infratemporal meridians actually is the least common location where we found ITC. The second question that we asked is what degree of ITC would be observed in eyes with gonioscopic angle closure. Now, notice that's actually a very interesting finding, because although all these eyes, by definition, they had angle closure, meaning that the trabecular meshwork was not visible for at least 180 degrees. But when we look at their OCT, only about a third of them had ITC iris trabecular contact for at least 180 degrees. So in other words, you see actually 2/3 of patients would not have anatomical angle closure if we are adopting this definition here. The third question we ask is how common it is for eyes with gonioscopic angle closure having no evidence of ITC. Again, looking at this graph shows the 36 angle locations. We're talking about the number of these angle locations with ITC. And we have about 15 to 70% of eyes actually had no evidence. So all the 36 angle locations we measured had no ITC. Now you can have an idea now for eyes with angle closure defined by gonioscopy, there is a huge variation in terms of the extent of ITC we see with anterior seminal CT. What is most interesting here is the degree or the extent of ITC is actually related to the risk of PAC and PACG. So by definition, PACS eyes had no elevation of IOP, but PAC, PACG, by definition, they had elevation of IOP. And it is intuitive, and it is by common sense, we know it is the case, where we found here using ASOCT data to support the argument we're talking about here. The more or the greater the extent of ITC is actually associated with a high risk of angle closure, high risk of primary angle closure and or primary angle closure glaucoma. And then what's interesting here is that a great extent of ITC, but not angle closure determined by gonioscopy, was associated with a greater risk of PAC or PACG in eyes with angle closure defined by gonioscopy. Now, coming back to this case, we actually have a very divided opinion. Half of our audience would perform an LPI and half of you would not. Now, I'm going to show you this picture. We have a little bit more information. Now, back then, with this pressure level, this patient is still regarded as PACS because there's no evidence of IOP elevation and PAS. But here, we have actually more than 100 degrees, about 180 degrees with ITC. Although I highlighted here, on the left, you can see there are some angle meridians with pretty big gap of angle opening. So this is the right eye, and this is the left eye. Left eye, we have actually more. I mean, the angle is narrow, but the extent of ITC is less than the right eye. So we're talking about having only perhaps 30 degrees of angle with ITC. The right eye having about 180 degrees, a little bit more than 180 degrees. Now, I would like to get your opinion again. Given this additional information, would you be more likely to perform LPI in this case, or since it is still PACS, or we just observe? Please pull out your smartphone, scan the QR code, and we would like to get your opinion. So we have this eye. Actually, I saw this patient a year ago, and I'm going to share with you what I did, but I would like to first collect your opinion. Given the knowledge we have on PACD, given the new study findings by Professor He Mingguang, illustrating the fact that a lot of eyes actually have very low risk of development of PAC or AAC, acute angle closure. With this background, how many of you would actually administer laser iridotomy for this patient? So actually now we have, instead of half-half, we have actually more audience opting for LPI. All right, very good. So this is what I did. I saw this patient back in September 2021, I discussed the diagnosis with the patient. I also, given the new finding, I share with the patient that the risk of PAC and PAAC development actually was quite low. We're talking about 2% if you're going to perform LPI versus 4% if you are going to observe over 72 months, about 6 years. So I offer the options of LPI versus observation, and the patient decided to be observed. So this is a mutual decision. We come to the conclusion that we were not going to do an LPI at that stage, but I carefully explain and warn the patient about the signs and symptoms of AAC so that actually she can seek emergency care as soon as possible once the symptom develop. She did come back just 2 months ago, and this is what we had. She had blurring of vision, VA dropped from 1.2 to 0.4, and she didn't have pain, but she complained of tightness. She noticed something is abnormal. The eye is not that red, a little bit of red, but she remembered what I told her. She came to me immediately, and what I noticed there was a epithelial edema. Typically happens as a consequence of elevated intraocular pressure. Pressure at that point was 64 millimeter mercury. Now, just a revision, we had this scan done a year ago, more than about 180 degrees with ITC, and this is what we had 2 months ago. We have pretty extensive of ITC. Now, the two angles I just highlighted over here, it was open a year ago. Now it's closed. Actually, all angles were closed, and that's why the pressure goes up. I typically do not perform LPI at this stage because is the cornea is dematous, the laser absorption typically would not be ideal. Many of us here would adopt medical therapy. The patient did receive Diamox topical low IOP lowering medication, but IOP remained high. So what I did was ALPI, argon laser peripheral iridoplasty, and the pressure actually came down to 25 1 hour after ALPI. It's a very easy procedure. I enjoy doing ALPI more than LI just because the allergy is much lower and I don't induce additional inflammation. This is what we see after a week. And you can see now the ankle being opened up. Exact the same two locations you saw with close angle with extensive ITC. Now you see the angles becomes open up. Now some part of the angle here you can look at, my arrows still remain close, but the opening is sufficient enough to actually draw the pressure down to 14 millimeter mercury. Fortunately, we don't have any nerve damage because the patient actually she's able to come to me at a very early stage. So there's actually not much change in the optic nerve. So the lesson to learn here is although it's very actually difficult to decide what to do with patients with PACS, actually we have a lot of patients with PACS, but a lot of them actually they don't have ITC, and PLI is unlikely to be indicated. And then for anterior segment OCT imaging, we know it is important to scan the eyes 360 degrees. The new technology we have now allow us to evaluate ITC in a more reliable manner. So we can identify the scale spur with the software, and then we can have a polar plot, have a very good idea about the extent of angle closure, about the extent of ITC. And it is useful to use this information to evaluate who is likely to be benefit from LPI. Now the question remains in terms of how much angle closure, how much ITC would you consider to do LPI? Now we have here a case, left eye, you can see there is a certain degree of ITC, about 30 degrees, and the left eye remains quite okay all along. whereas the right eye having more than 180 degrees of ITC, this eye developed acute angle closure in about a year. We don't have any evidence right now telling us, informing us what to do in terms of using OCT for decision-making in patients with PCS. We are undertaking a clinical trial to address this point, but I guess it is very useful for us to study the ITC using ASOCT to better inform who is going to benefit from LPI. So this is what I want to share this afternoon. Thank you very much for your attention.
Thank you very much, Professor Leung. Thank you for taking us on a journey on the ASOCT and what can its benefit in terms of seeing which patients may benefit from intervention versus observation. To those who may have questions during the presentation, please type your questions in the comment section and we will address it later on. Moving on, may I call on Professor Kee-Ho Park to introduce our next speaker?
Thank you. Our second speaker for this webinar is Professor Kyung Rim Sung. She is a professor of Department of Ophthalmology at the Asan Medical Center, University of Ulsan College of Medicine. She was the director of scientific program of Korean Glaucoma Society, director of scientific program of Korean Ophthalmologic Society, co-chair of scientific program of 2021 Asia Pacific Glaucoma Congress. She graduated Seoul National University Medical School and completed fellowship at Asan Medical Center and University of Pittsburgh Medical Center. Her research interests include pathogenesis of angle closure glaucoma, pseudoexfoliation, glaucoma imaging, and basic research related to gliosis and glaucoma. She received several worldwide renowned awards, including the AAO Achievement Award, and published 164 peer-reviewed articles in international journals. Professor Sung will deliver a talk on insights in the latest diagnostic innovations. Professor Sung, please.
Hello, everyone. In this talk, I'll be speaking about the role of OCT and geography in the glaucoma diagnosis. Glaucoma is defined as characteristic change in the optic nerve head and accompanying visual field deficit. And these structural and functional changes are expected to progress, which may be detected by the progression analysis. Therefore, to perform accurate diagnosis, careful observation of the optic disc, for instance, neuroretinal rim thinning, optic disc hemorrhage, RNFL defect, and their change detection is almost important. Approximately 20 years ago, OCT, which can quantitatively and objectively assess the RNFL thickness, has been developed and in use worldwide for the diagnosis of glaucoma. Further, OCT allowed us to measure macular ganglion cell layer thickness, which is also useful to assess the glaucomatous changes detection. In this case, macular change detection was earlier than the RNFL thickness change. In terms of functional measure, along with conventional standard automated perimetry, paraneurgy and multifocal VEP can be used, but these electrophysiologic tests are limited by higher signal-to-noise ratio and lack of normative data. So still, SAP remains the reference standard for assessing glaucomatous functional damage. Those structural and functional damages do not occur simultaneously. unveil thickness change is known to precede functional damage assessed by SAP. So in early glaucoma cases, structural changes can be useful, while visual field change can be helpful in moderate to advanced cases. However, both strategies have pros and cons. For instance, in advanced cases, unveil thickness reaches measurement poor and thus not sensitive enough to detect change. Further, in those advanced cases, test-retest variability of visual field is very high, and subsequently it is sometimes problematic to detect progressive change using visual field in advanced glaucoma. As there has been unmet needs for another effective measure for glaucoma's change. So the role of OCT angiography, peripupillary vessel density, macular vessel density, and dim layer optic nerve head vascularity is an expected area of interest in the diagnosis of glaucoma. In order to incorporate OCT angiography in clinical care, we needed to know the characteristics of the OCT angiography-driven parameters. So 6 years ago, we investigated the features of peripupillary vessel density, superficial vessel density, and found it was similar to RNFR thickness, like having two peaks for superior temporal and inferior temporal area. And it becomes greater as it closer to optic disc margin. When we assess the factors associated with the vessel density, peripupillary superficial vessel density was related to glaucoma severity parameters like visual field MD and RNFR thickness, while the vessel density was related to axial length. But the vessel density was affected by the projection artifact. So it may not be helpful for the glaucoma diagnosis. We also evaluated the effect of age on global and sectoral vascular parameters of the peripupillary area and macular area in healthy eyes using OCT angiography, and found age substantially affected vessel density in most of the peripupillary sectors and macular areas, like RNFL thickness. In the next paper, we tested the possibility of enhancing glaucoma diagnostic capability by combining two modalities, OCT and OCT angiography. So when these two parameters were combined, both sensitivity and specificity were enhanced. And among the 131 eyes, 32 eyes were misdiagnosed as glaucoma by OCT, but accurately diagnosed by normal by OCT angiography. These eyes were more myopic with a longer axial length and thinner and temporarily displaced peripupillary and RNF thickness. So in these cases, OCT angiography may be better than OCT for glaucoma diagnosis. So in combined use, both OCT and OCT angiography can complement each other in the diagnosis of glaucoma. A recent study from UC San Diego group documented the models, including OCT and OCT angiography parameters, had higher classification accuracy compared with those individual subsets of OCT or OCT angiography features alone, including hemifield measurement. And those combined models significantly improved the model's classification accuracy compared using global parameters alone. So including longitudinal rate of change of OCT A and OCT parameters considerably increased the visual field progression prediction capability when compared with the baseline measurement or the single strategies. What about advanced cases? We investigate the progression detection capabilities of circumpapillary and macular vessel density in advanced primary open-angle cases. Using the rate of change in vessel density, we adopted variability limits derived from healthy eyes, so using event-based analysis. We found vessel density loss showed better progression detection capability than structural loss in advanced POH cases. So the detection of circumpapillary vessel density and macular vessel density loss may be useful for detecting progression in advanced stages of POH to complement each other. And these eyes, which RNA field thickness cannot provide useful information because of advanced stages, peripapillary vessel density measurement showed concordance with the visual field parameters. When we tested the progression detection capability in opposite unaffected hemifield, in those single hemifield defective patients, ONH superficial vessel density and macular vessel density performed better than the RNA field thickness change. Interestingly, superficial vessel density showed reversibility after substantial amount of IP reduction. And those IP reduction and reversibility of vessel density was related to lamina cribrosa depth change. Of course, this reversibility did not occur in all eyes underwent glaucoma surgery, but it may suggest that OCT angiography is an effective approach to evaluate the postoperative microvascular status of the eyes that underwent trabeculectomy. What about deep layer microvascular dropout? Deep layer MVD is an also interesting find which can be assessed by OCT angiography. OCTA-driven microvasculature dropout in the optic disc was strongly related to the presence of microvascular dropout in the peripapillary region. So this optic disc MVD and parapapillary choroidal MVD was closely related, which is a very interesting finding. Dr. Lee and Kim, their group intended to determine which groups of porosity factors best explain the rapid progressive RNA thinning in patients with primary open-angle glaucoma. They found that the regression tree models demonstrated that larger lamina cribrosa curvature index and then the presence of choroidal microvascular dropout, CMVD, were the first and second porosity factors for faster RNA thinning. So including this study, numerous studies show that clinical relevance of parapapillary CMVD detected by OCT angiography in the rapid progression of glaucoma. We sought to investigate the association between optic nerve head choroidal microvascular perfusion status and optic disc hemorrhage in primary open-angle glaucoma patients using swept-source OCT angiography. Among POAGIs, those with the optic disc hemorrhage had lower intra-disc vascular density and those without optic disc hemorrhage. As all appreciate, this optic disc hemorrhage is a strong indicator of glaucoma progression, and it is closely related to intra-disc optic disc vasculature. In the following long-term study, we found that with the similar level of baseline visual field, eyes with lower intradisc vessel density showed faster progression. So hence, along with parapupillary choroidal MVD, we noticed that intradisc vessel density is an important marker for clinical prognosis of glaucoma. And recently published paper from Dr. So, they found that optic disc microvascular dropout, which indicated the deep layer of vascular perfusion, is also related to mechanical LCD formation, lamina cribrosa defect. This is a very interesting finding, which proves that vascular parameters are also connected to mechanical damage occurred in glaucoma lamina cribrosa. Our data also suggests that steep lamina cribrosa was correlated with reduced lamina cribrosa vessel density. So in summary, OCT, a measured peripapillary and macular vessel density, can be an ancillary biomarker for glaucoma diagnosis, which may complement conventional structural and functional assessment. And dim layer, peripapillary choroidal and intradisc microvasculature assessment is currently providing interesting findings which can help to explore glaucoma pathogenesis and also diagnostic clue, which is naturally useful for glaucoma patient care. So I'm using OCT angiography in my clinic, but still it is lack of reference, the normative classification or comparative values. And this is still limited in many aspects, but I think OCT angiography can be useful for in the future, but we still need several aspects for active clinical patient management. Thank you very much for your attention.
Thank you for sharing your expertise with us, Professor Sung. Now we will have the Q&A session. Please type your question in the section if you have any. Tony, could you start the questions in the comment section?
Yes, Professor Park. There's a couple of questions here, I think, addressed to Professor Leung. There's one question is your settings regarding argon laser peripheral iridoplasty. And I think a related question, what's your technique if you have a patient with acute angle closure? There's it's quite close to the cornea. What's your technique in opening it up? I think that's what the question was pertaining to.
Right. So I love doing LPI more than LI. Just I mentioned is a very actually straightforward procedure. The setting actually is always related to the condition of the patient. We often start with, I have to lay out the principle first. The idea here is we have to provide energy just sufficient enough. You don't need to burn the iris. If you see a char of the iris, if you burn the iris, that's not the right way to do. The principle here is you pull open the iris using a mechanical force induced by your laser energy. So the key here is you start off low setting, low energy, but you have to have a little bit larger sample spot size. So I usually would start out with 0.2 second or 200 millisecond. And then the spot size, I would aim at least 400 micrometer. So it's relatively larger spot size than we typically use for other PRP or LI procedures. And then we are talking about an energy level. You can start off with 200 milliwatts. Now, if you don't see anything, you can then gradually either lengthening the duration a little bit or increasing the energy level a little bit until you can see iris movement. So as soon as you can see some movement, if it's sufficient, basically. You don't need to really get high energy to create a big contraction. We perform typically about 10 to 15 spots over 360 degrees. As what you can remember, the slide I showed earlier, ITC most often is severe over the superior and inferior meridian. So that part of the iris is actually quite difficult to pull open. But for many eyes with acute angle closure, they would have 360 degrees of ITC, and targeting over the horizontal meridians, 0, 180 degrees, that line, that meridians would generally be very effective to pull open the angle. And then you can see also pretty fast reduction of IOP right after the procedure. So in general, actually, we have pretty good evidence from the literature that LPI is effective and safe in patients with acute angle closure. We are not so worried about damaging the corneal endothelium, just because if you're not going to do LPI, you have to do LI. The energy that you put on is actually much higher. The probability of damaging the cornea is actually, I would say, greater if you perform LI compared with LPI.
Okay, thank you, Dr. Professor Leung. There's a question here for, I think, Professor Sung. With what you've shared with us, how do you foresee the role of OCTA in management of glaucoma, considering that we all know we have a lot of longitudinal studies with OCT, RNFL, GCA in relation to the visual field? How do we incorporate? Do we do all of the tests? Do we specifically do OCTA in a particular type of patients? Although, as you said earlier, it might not be ready yet for prime time, but it has some potential. Can you enlighten us?
Thank you for the question. Can you hear me?
Yes,
you hear me?
very well.
Okay. I think, frankly, it is a little bit immature to use OCT angiography actively in the clinical practice because they do not still provide normative classification or any proration chart, as far as I know. So I'm interested in OCT angiography because I'm doing research, but in the clinical practice, it may not be easy to incorporate, but I'm using that in a quite qualitative way. You can see the reduced vascularity and in the images. And in sometimes, as I mentioned in my presentation, in very advanced cases, OCT angiography reduction of vessel density is quite sensitive than compared with RNFL thickness change. So it may add a little bit confirmation in the proration or stability. So in my clinical practice, I'm using for two purposes. In advanced case, proration detection, and in more subtle case, like visual field is unreliable and OCTA image is not that quite good, quality is good. And I need one more strategy to confirm my opinion or decision. It may add a little bit. I think future is good, but we are still in the middle of engaging in the clinical care.
Thank you, Professor
I'm also
Sung.
curious
Maybe
about
just
Dr. Park and Leung and Tony.
yeah.
What are you using that?
Professor Leung, do you use OCTA?
Well,
or what do you think its future?
right. So we do collect data from OCTA in our patients, but just like Professor Song, we are collecting the data largely for research purposes. For clinical application, it's really hard at this stage to, to adopt it in a routine practice, just because we also know artifacts are more common with OCTA than OCT, nerve fibrillary or GCI pale thickness analysis, and it also takes longer time. So all these factors make it a little bit more difficult to adopt it routinely in clinical practice. That said, doesn't mean OCTA would not be relevant. I think the holy grail here is when we are able actually to have longitudinal data, prospective study demonstrating that perhaps there are changes at the optic nerve head or in the inner retina that can be predictive of, say, future loss of the nerve fiber layer or visual field. That would be very interesting.
Yeah, similar to the study that you did, the longitudinal study with the RNFL and the visual field, I think you did a few years back. That would be a good if a similar study would be done in OCTA, and I'm sure a lot are investigating that. Professor
Yes.
Park, any comments? Oh, maybe here's another question. The microvascular changes, would you think it is the cause or the effect of glaucoma tooth damage?
I think we don't know.
Yeah.
Sometimes I think it's kind of secondary change. I'm more convinced that vascularity reduction is also secondary change related to the sick ganglion cell or so, but we're not sure.
Okay. Professor Park, any questions? I think. Well, maybe another question for Chris.
For the question, my internet connection is
Maybe going back to Professor Leung. Again, OCT has given us another dimension in looking at the iridocorneal angle. Aside from looking at the ITC, which of the parameters would be a good predictor for those who will progress from PACS to PACD?
Well, the typical measurements we can get from anterior segmental OCT include ITC, I just mentioned, but it's a measurement we derived from AOD, angle opening distance, or TISH, or iris space area. So these are the common parameters we use in the clinic to quantify the angles and to document the presence of ITC. I think the challenge here is the availability of the 360 degrees measurements is still relatively recent, and we don't yet have very good data using anterior segmental OCT for 360 degree. We have some data in the literature using the horizontal scan, vertical scans to measure the changes of this angle dimension over time. But I think the key here is we really need to look at the whole anterior segment in order to have a more precise understanding of what's going on in the different parts of the angle over time. We now have the device and we now have the technologies for 360 imaging, and I hope the question you're asking can be addressed in a few years' time.
Okay, thank you for that. Do you think with what you've shown us also in your talk, Professor Leung, do you think we're overdiagnosing angle closure through gonioscopy versus through OCT? Were you alluding to that?
I believe it is the case. I mean, here in Hong Kong, I see a lot of PACS patients being asked to have an LI. Which, although overall the safety level of LI is very high, but in terms of the cost and time that we invest in the clinic, I'm not too sure whether it is the cost-effective way. Very unlikely, in my opinion. So that's why we need the technology to help us for risk stratification to determine who is really be beneficial having LI. So that's why, as I mentioned, we're collecting data. We need RCT, we need an F1 clinical evidence to guide us what to do.
Okay. There's a few more questions in the chat box. I think it's more on the technique on the laser peripheral iridotomy. Which position is better for LPI? What lens?
Well, as I said, the horizontal meridians are typically a little bit more open than the verticals, and it's also a little bit easier to open a close angle over the horizontal meridians and the vertical ones. As you can recall from the slide, the patient that I did ALPI, we can open up more than 180 degrees of angles. But the vertical meridians, they are kind of very difficult to open up. But we were able to get the pressure down. So the idea here is, as I said, target at the horizontal meridians. It would get you an open angle, and that can also give you ways to open up the parts that are difficult to open. And you can use any types of gonal lens. The one that I use, the Abraham laser iridotomy lens. So it's the typical lens you use for. It's not mine. So it's the same lens that I use for LI and LPI.
Okay, thank you very much. Professor Park, do you have any questions?
I have a question to Dr. Sung. Microvascular dropout is a very important finding, but sometimes we can only see under the part region of peripapillary atrophy. So what is your view in case of myopia? Only the peripapillary atrophy is in some region in myopic eyes, and in glaucoma, typically it is associated with RNFL defect and rim thinning. Is there any your tip you can differentiate between myopic change and glaucomatous change in terms of microvascular dropout?
Recently, thank you for the good question. Recently, using Swepsosity, we can identify microvascular dropout within disc. Microvascular dropout within disc is very closely related to parapapillary choroidal vascular dropout. So, in many cases, parapapillary choroidal vascular dropout without disc MVD is usually from myopic eyes. That means only CMVD eyes, peripapillary CMVD eyes had longer axial length, and peripapillary disc dropout plus within disc dropout, that eyes is a little bit less myopic. So I think that may be some clue. So if myopic eyes within disc vasculature can be higher. Does it make sense?
Yep. Thank you.
So it is important to figure out within disc microvasculature, which is closely related to peripapillary vasculature dropout.
Yeah.
But not always. Yeah.
Thank you very much. I have another question to Chris. In iridotrabecular contact seen by anterior OCT, can you differentiate it? It is due to appositional closure or synachial closure? Is there any tip for you?
Yes, we can. You can differentiate synachial closure versus appositional closures statically and dynamically. For static assessment, you can study the angle configuration. For appositional angle closure, the angle configuration is commonly acute, whereas the adhesional type is more often obtuse. This is the way that you can study it statically. For dynamic assessment, you can do this using light and dark. You can collect images in light and you can collect images in dark. If it is appositional, you see the angle would open up in light condition, or you can actually apply pilot capping. After pilot capping, if the angle can open up, it's appositional. If there's no change, it's likely adhesion.
Those are excellent tips, Professor Leung. I think that's very usable for everyone in terms of determining a positional versus nickel. Any other questions, Professor Park?
No further questions?
Yeah. Maybe one last question for Professor Sung. With the conventional imaging modalities we have right now, and also the functional, the visual field, and the retinal nerve fiber layer, and the ganglion cell complex using the OCT, maybe you could share with the audience which ones are more important depending on the stage of glaucoma. You mentioned that briefly at the start of your talk, but maybe you could elaborate some more.
Thank you for the question. I think it's pretty much depend on the severity and the quality of the test. So in the early stage, it is quite important to look at the optic disc itself and RNA field defect and OCT RNA field analysis. Well, in moderate to advanced stage, functional changes detection by visual field is more important and maybe relevant to patient quality of life. But every test has its own limitation that may be related to patient's specific eye condition or the test environment or so. So we may use accurately, wisely combining those modalities in those cases. So that may depend on several aspects. I think, optic disc examination, stereoscopic optic disc examination photo and RNA field photo is the most important thing, which I'm using most frequently in my clinic because it's very familiar to us a long time. And it's quite providing many clues which may not be explained easily. It's like a vessel position change or minor, very subtle texture change, which Chris is actively research. So that we can notice the texture change by looking at the photo sometimes. So that's all.
Okay.
Thank you very much.
Yeah, now we have to close. Big thanks to our speakers and all of our attendees today.